what we call the anti. Is prostatic urethra. So, and it is this point where the semen is also coming in. So you see that if this place is not blocked, this one has a tendency to backflow. Okay, this has a tendency to backflow. So for it to continue to move forward, then this point should be blocked. All right, this point should be blocked. All right. And this is the actual phenomenon of ejaculation, which we call antegrade ejaculation. So I'm getting the message that my mic is breaking. I don't know. Right. Is it the same for everybody? Unfortunately, I'm not using a mic. I'm just talking through the laptop. Okay, thank you. I hear it's okay now. Thank you. So this is the normal ejaculation process, which will now allow the semen to flow forward, outwards. When I say forward and outwards, it means that forward here and then out of the penis. So that is antegrade ejaculation. Now, we normally don't bring the antegrade because normal ejaculation is known to be forward, I mean, progression. And so if you bring the antegrade, it's just like a tautology. But I'm bringing the antegrade here because we are now going to introduce retrograde. So this is supposed to help you that the normal ejaculation is forward movement. So it's the antegrade. Now, if you move to the next slide, then we are going to now talk about the retrograde ejaculation. And then we said that retro means backwards. Retrospective study. If you're doing a retrospective study, then the work has been done already. You are now going to look at it, a review of it. So retro, backwards. Now retrograde, backward movement. And so this is how it happens. So like we said, during normal sexual activity, before the ejaculation will take place, the bladder neck should close. All right. And then when that happens, then it means that it's going to prevent any backflow of any fluid into the bladder. Remember, the semen is not coming from the bladder area. The semen is coming from the seminal vesicle tract. And however, they join the prostate at the point where the urethra they join the urethra at the point where the urine should also come in. That's why it is important that the bladder neck should close so that it doesn't cause urine and semen to mix up. All right, good. So here with the retrograde ejaculation, it happens when the bladder sphincter, or for that matter, bladder neck muscle fails to work properly. And how should it work properly? It should work properly by closing. And we said that it will close under the influence of the sympathetic nervous system, which will contract. All right. So if there's any problem which will affect the proper functioning of the sympathetic nervous system, then it is going to affect the proper closing of the bladder neck. And for that matter, leaves a space for semen to also backflow. All right. So let's see the next slide. So here, remember from the previous slide, you saw the semen from the seminal vessel coming this way. Sorry. Coming. Sorry. Yeah. So coming from up here, down to the outside. Here, we are now seeing the semen rather, instead of coming downwards outside, going to go backward because the bladder neck closure has been compromised. The bladder neck has failed to be closed. So once it has failed to close, then it gives a gateway for the semen to go. And where will you go now? It will go into the bladder. All right. So this is what we call retrograde ejaculation. Now we're going to talk about two things. So moving backwards. Now, if the bladder neck is completely open, all right, if there was a failure of closure at all, then everything will go back into the bladder. Everything will go back into the bladder. That will be complete retrograde ejaculation. And in that case, you see that since everything is going into the bladder, then there'll be nothing to come out. There'll be nothing to come out. So in that case, you don't even talk about reduced ejaculate volume. There is nothing coming out. So we call that aspermia. Aspermia, we're not talking about, people confuse aspermia with azoospermia. The word zoo is talking about animals. I'm sure all of us know about a zoo. A zoo is where you keep animals. So when we talk about zoospermia, so the spermia is talking about the total semen. All right. Now, when you talk about zoospermia, you're talking about the animals in the semen. And the animals in the semen are the sperm cells themselves. So if you say zoospermia, then you're talking about absence of sperms in the semen. But if you say aspermia, you're talking about absence of the semen. So those are the two things that you should not confuse. And I'm sure when you're doing the semen terminology aspect, you appreciate that very well. But I'm saying here now, here, the semen is supposed to come from up here, down and out. Something has happened and we are seeing it going back into the bladder. I'm saying that if the bladder neck is completely open, then everything will go. Once everything goes, remember, nothing will come out. And so you have a sense that you have ejaculated. And meanwhile, there is nothing coming out. Remember that ejaculation is the physical ejection of the semen coming out. This is pushed by a phenomenon you call orgasm. All right. So people try to use the two, but they are never the same. The orgasm is the feeling that you get, the pleasure, the climax of the pleasure that you get. That's the orgasm. It is normally associated with the ejaculation. But the two are never, they cannot be the same. The ejaculation is the fluid which is coming out. The orgasm is the pleasure, the physiological pleasure which the body enjoys. All right. They appear to go hand in hand, but they are never the same. So if you have the orgasm, it means that it's like there's a car, you are pushing it. So the push is there, but the car is not moving. It means that something is blocking it. Right. So if the push has occurred, yet nothing is coming out, then it means that the semen has gone somewhere. And we call this, let me take you to the next slide. We call it dry orgasm. Dry orgasm. Now, let me take my time again. We are saying that the semen should come out. Now, in retrograde ejaculation, you're also saying that the blood is going in there. Now, there are two things that can happen. Either it has opened widely, said that everything is going there, everything is going to the bladder. In that case, nothing will come out. nothing will come out. So the body has gotten the sense that that satisfaction has location. That's orgasm, but nothing came out. So we call it dry orgasm. Now, in that case, then it means that all the semen went into the bladder. Now, if the closure, yeah, there was a closure, but except that the closure was not too tight, then it means that in that case, some will go into the bladder and some will come out. So in talking about retrograde ejaculation, two things, either it was partial or complete. When it is complete retrograde, it means that everything went. In that case, your semen volume will be 0. Now, if the closure was only partial, then some will go into a bladder and some will come out. This is all that you're talking about. But people try to make it look as if when you are talking about retrograde ejaculation, it means that everything has gone. All right, if everything has gone, then that makes it complete. All right, but if some, especially when you have reduced, remember that we said earlier that when there's reduced ejaculation, you suspect retrograde ejaculation. But your suspicion should be based on the fact that then the retrograde ejaculation is not complete. Because if it were complete, then you wouldn't even have reduced volume. All right. So those are the two aspects of retrograde ejaculation. You have the partial or incomplete one. That one will give you reduced volume, which we also call the hypospermia. We also have one where it is complete. The bladder neck didn't close at all, and so everything went into the bladder. And then you're having the dry orgasm or aspermia. Aspermia, absence of, not absence of sperms, but absence of semen. All right. Okay, let me see. I'm getting some points here. Okay. All right. Okay. So those things that are not on a slide, which you think you have to make notes, please do. And you can ask questions. All right. Now, when will a clinician suspect retrograde ejaculation? All right. Because, for example, if you were in your lab A, a person came to do semen analysis there, and then for you, you have reduced semen volume. All right. If the doctor asks the patient to go and repeat the test in another lab B, you wouldn't know. The doctor will not have the benefit of saying that, oh, you did the test in lab A, your semen volume was low. You did it in lab B, your semen volume is still low. Then the doctor will begin to suspect, then probably let me investigate for retrograde ejaculation. But if you did it in your lab A alone, and you saw, you found that the volume is low, you cannot conclude, you cannot predict that there's retrograde ejaculation. But I don't want you to, in your haste to exhibit your knowledge, you go and then also mess up. So if you have it one time, please don't rush to suspect that there's retrograde ejaculation. At best, you can request for a repeat test to rule out retrograde ejaculation. You can do that. So your first test gives you a low volume. All things appear to be normal, but also low volume. So in your comment, you can say repeat tests, let's say in 10 days time, to rule out. All right. Then you are making sense. But in your just one test, you can't say that comment, retrograde ejaculation suspected. No, you can't do that. All right. Now, but the clinician can do that because he had the benefit of getting the patient do the test from different angles or different labs, and then collating the reports and seeing that each of the tests that he has done recorded low volume. So that would be a basis for the doctor to suspect that there could be retrograde ejaculation. If the patient also tells the doctor, oh, anytime I engage a woman, I don't see anything coming out. That's what we call dry orgasm. The patient, the individual will get a feeling that yes, he's satisfied, but nothing comes out. That's what we call a dry orgasm. And the fact that nothing is coming out is what we call the aspermia. Now, so if nothing is coming out, the question is, where did it go? All right, then that could also be a reason to suspect. All right, then there's also this observation of cloudy urine post-orgasm. We didn't say post-ejaculation here because the patient himself have told you that when I engage a woman, nothing comes out. So it is a coming out of the semen which we call ejaculation. So if nothing has come out, you can't say that you are doing post-ejaculation. But at best, you can say that it's post-orgasm because anytime there's that kind of satisfaction, that's orgasm. So post-orgasm is when you have had the feeling that, yes, I've enjoyed, yet nothing comes out. Then you produce urine. The urine becomes cloudy. Straight away, that gives you the indication that, what has made the urine cloudy? The urine cloudy could give you a strong suspicion that instead of the semen coming out, it went into the bladder, and it is the mixture of the semen and then the urine in the bladder which has occasioned the cloudiness. All right. So when you have all these scenarios, it should give you a strong suspicion that there could be retrograde ejaculation. And therefore, now you could do a test to actually confirm it. All that we are saying, all these things you're saying are all suspicions. All right. So what tests will you now do in the lab to confirm your suspicion? All right. So, all right. But before then, let's look at causes of the retrograde ejaculation. I think we've said this over and over again. Closure of the bladder, neck, and seminal emission are initiated via the sympathetic nervous system. Right. So if there's anything that is disrupting this reflex action, then there could be retrograde ejaculation. We said this. All right. So the RE is retrograde ejaculation. It's also associated with dysfunction of the internal uterus sphincter. Like we said, the internal uterus sphincter should also be able to open and close. All right. So we've also talked about common causes of retrograde ejaculation also include neuropathies. We said that in the process of the ejaculation, we talked about the role of the neurons. We talked about the messengers, the nitric oxide. All right, how they are able to work out so that there could be the ejaculation process could occur. Now, anything which is disrupting all these phenomena could give you retrograde ejaculation. So, and I made a point here that one of the first signs of diabetes is retrograde ejaculation. Why? Now, most men may not even if they don't even know that they have diabetes, or even if they have diabetes, they think that they are controlling it. And they only go and see a doctor when they begin to feel signs of erectile dysfunction, or for that matter, ejaculatory challenges. There, every man will go and see a doctor. Now I can't perform, or even when I perform, this thing is happening. So one of the things that would take a clinician, a patient to see a clinician is when there's this kind of ejaculatory challenges. So any doctor who is also investigating retrograde ejaculation, and for that matter, erectile dysfunction, will rule out diabetes, because diabetes is one of the key metabolic medical conditions that damages neurons. So I'm sure you know about diabetic neuropathies. Whenever you have diabetes, they have high risk of damaging the neurons. All right. So once that is the case, and we also know that a lot of these activities, sexual activities, including erection and ejaculation, are all influenced by the neurons, action of the neurons. If the neurons are damaged, then of course, for it. So any doctor who is investigating erectile dysfunction will rule out diabetes, because uncontrolled diabetes will necessarily damage your nerves, and to the extent that you have what we call diabetic neuropathies, speaks volume about this situation. I think we've talked about a lot of these things. Common surgical causes of retrograde ejaculation. Of course, if there is a surgical intervention in the bladder area, it could also compromise the muscles that control the bladder neck. Either colorectal surgeries, transurethral prostatectomy. We said transurethral. Of course, you know about prostatectomy, removal of the prostate. Now, if there's a new technology where instead of opening up, they rather will use an instrument through the urethra, so transurethral, to the prostate area and do the surgery there. All right. Now, this also have a tendency of compromising on the bladder muscles, and therefore could give you retrograde ejaculation. We said that anything that can compromise the bladder neck, and for that matter, the urethral sphincter, will not allow these two mechanisms to close properly. If they don't close properly, then of course the semen will have easy task of moving backwards into the bladder instead of coming out. All right. So we also have the transurethral resection of the prostate. These are all surgical interventions, and any of them have the tendency of also disrupting the bladder neck, which will lead to retrograde ejaculation. All right. Then this is the area which we must take very good note of: laboratory diagnosis of retrograde ejaculation. All that we said about will give you a suspicion. The suspicion can come from the clinician, can even come from an experienced laboratory scientist. Especially with this knowledge, you can easily now also suspect somebody for retrograde ejaculation, or you want to also recommend that the patient be investigated for retrograde ejaculation. Now, for all urine analysis, there is physical examination, there's chemical examination, and then a microscopy for every urine analysis. Now, so here you're going to collect urine, you are going to do urine analysis, but the urine is not going to be early morning urine. Neither is it going to be midstream urine or terminal urine. I'm sure all these types of urine have specific reasons of their collection. When you're talking about early morning urine, you know why you're collecting early morning urine and for what. If you do about midstream urine, you know why you're collecting the midstream urine and for what. If you talk about terminal urine, you know what is terminal urine and then how is it going to be used for. If you talk about 24-hour urine, you know what. So everything. Then we are going to talk about post-ejaculation urine. Okay. Remember, we also talk about post-orgasm urine. All right. So post-ejaculation urine and post-orgasm urine are all can be used interchangeably. In the first scenario, talking about somebody who says that when I do any sexual intercourse, I get a feeling that I have orgasm, yet nothing is coming out. When you are collecting urine, it cannot be post-ejaculation, because ejaculation is always the coming out of the semen. So if nothing comes out, the urine that you have collected cannot be post-ejaculation urine. So take note. They appear to be the same, but technicalities. You should know the technicalities. So there's a little difference between post-ejaculation urine and post-orgasm urine. In post-orgasm urine, we're talking about a situation where the person may have had what we call the complete retrograde ejaculation, where everything went into the bladder and nothing comes out. So the semen volume is zero. In that case, you cannot talk about post-ejaculation. You're talking about post-orgasm. The person had orgasm, all right, but nothing came out. And therefore, the probability is that all the semen has gone into the bladder. All right. So when you are now collecting the urine after the exercise, that would be post-orgasm urinalysis. Now, if this person, some of the semen came, except that is low or low hypospermia, low volume. If it's low volume, it means that there is something came out. You are suspecting that what came out is not enough, and that some may have gone into the bladder. So then that becomes post-ejaculation urine. However, whether it's post-ejaculation or post-orgasm urine, the procedure for analysis now becomes the same. I just wanted you to know when to use post-orgasm and when to use post-ejaculation. So in every analysis, there is physical examination, there is what do you call it? Chemical examination, and there is microscopy. So with this, your physical examination is very simple. Physical examination, the urine should look cloudy. So if the urine is clear, then that in itself is likely to rule out the retrograde ejaculation. I'm hoping that you are following the discussion. So I'm saying for every urinalysis, you're going to do physical examination, chemical examination, and then the microscopy. In post-ejaculation urinalysis, your microscopy, for that matter, your physical examination, you are going to comment on the appearance. If the appearance is cloudy, it gives you about 80% assurance that yes, this could be a case. It could be a case. All right, so we talk about the and here you can put this one that I think I didn't include the physical examination here. So here for your post-ejaculation analysis, your appearance, or for that matter, microscopy or physical examination, we should talk about appearance. And here we are talking about the appearance is likely to be cloudy. All right. If it's clear, then that is a strong indication that what you are suspecting is unlikely to be the case. Then we are going to look at your chemical examination. The chemical examination, we are not going to look at protein, sugar, and bilirubin and the dipstick. No, you are going to look for fructose. You are going to look for fructose because your suspicion is that you are remember we talked about the seminal vesicles producing the largest volume of the semen proportion, which is about close to about 70%. And the seminal vesicles also produce fructose to feed the sperms. So your biggest, most important chemical parameter there will be the fructose. So you're not going to look at glucose or anything. All right. So you do a test for fructose. All right. And then, of course, your microscopy, you're also going to look for sperms in the urine. So these are the three things that you do on post-ejaculation urinalysis. Your physical examination, which is the microscopy, you're going to look at appearance. The Benedict test that reduce. Of course, glucose will reduce, lactose will reduce, fructose will reduce. It is only sucrose that does not reduce. I'm sure you know this is from your basic sciences. Sucrose will not reduce, but fructose will reduce, glucose will reduce, lactose will reduce. All right. Now, so when that's why, and up to date, people talk about urine sugar. Hardly do we talk about urine glucose, because the methodology for testing for sugar in urine was based on the Benedict's reduction method. All right. Now, so with the Benedict's reduction method, when the test was positive, you cannot say that it's glucose, because it could be glucose, it could be fructose, it could be lactose, it could be any of the reducing sugars. And so once the test is positive, you have no justification to say that you are testing for urine glucose. And up to date, people are still talking about urine glucose. However, now we are using the dipstick, which is based on glucose oxidase. And the glucose oxidase technique is enzymatic. And once it is enzymatic, it means that it's more specific. And so now if you use the urine strip to test for glucose and it is positive, you cannot say that is urine sugar, even though the glucose is a sugar, but you are specifically dealing with glucose because the test was based on glucose oxidase. And for that matter, if it is positive, you could conveniently say that it is urine glucose. However, we still continue to do our, we still report as urine sugar. So if you want to differentiate between, let's say, fructose and glucose, what you could do is to do the Benedict test. Benedict test these days, like I've said, we don't do it. We hardly do it. But there is a tablet form which you call the clinic test. The strip form is called Clinistix. I'm sure you know these things already. Clinistix. That's the strip or the stick, which is based on a glucose oxidase method. Clinic test is a tablet form, which is based on the Benedict test. And so if you did the Benedict test and it was positive, you can only say that it's glucose, sorry, it is sugar. So if you did the strip, so that we now use every day, everybody uses the clinic, and then the glucose portion is testing positive, then it means that the test was actually for glucose. To rule out or to confirm that it is fructose, what will happen is that the clinic test will show positive and your Clinistix, which is the urine strip, will show negative. If the clinic, because the Clinistix is specific for glucose, so if fructose is there, the Clinistix will show negative. However, the clinic test, which is based on the reducing properties of sugars, will show positive. It is very, very simple, except that we don't have clinic tests. And as students of andrology, and with this knowledge, I'm sure we can do that. In fact, clinic tests, they are not available on the market, but they are available if you want to get some. You can get some from other markets. not the Ghana market, because our suppliers will want to deal with fast-moving items. So since everybody is now doing the clinistics, and for that matter, the strip, multi-sticks, nobody will go in for the clinic test, which I've said that one is a tablet form, based on the reducing sugars. All right. I hope my point is clear. And then the microscopy, of course, you do your spinning, then you retrieve your pellet, and for that matter, sediment or deposit, you look for semen, or sorry, you look for sperms in it. Right. So the diagnosis of retrograde ejaculation using the post-ejaculation urine. Right. What if both tests for fructose and glucose shows positive, especially in case of patients with history of diabetes? That's a very fantastic question. So, a very fantastic, yes, that's fantastic. It means that you're following the discussion. So it means that you have already ruled out glucose. You have established the patient is diabetic. If diabetic, then, or you are already also suspecting that you could also have retrograde ejaculation. Then both could be positive. All right. So that makes it really simple. This one is also positive. All right. So, but you have already established that the patient is diabetic already. And we have also established that diabetics are prone to retrograde ejaculation. Remember, in all this, you want to confirm retrograde ejaculation. So it makes the thing even more easier. It's a patient who is diabetic, all right. And once he's diabetic, he's prone to having retrograde ejaculation. And he also have a history of hypospermia, low ejaculate volume. So those things will rather to confirm the diagnosis the way it is. So I think I also like your question because it means that you are following the discussion very, very, very well. Thank you so much. So we move on. The diagnosis of the retrograde ejaculation using the post-ejaculation urine. Now, so detection assessment of significant number of sperms in post-orgasmic urine is diagnostic. What it means is that the detection alone, the detection of sperms alone doesn't confirm your retrograde ejaculation. Remember that in the retrograde ejaculation, you are saying that the sperms or the semen has gone into a bladder. All right. Assuming that it didn't even go and everything came out. Remember that the urethra has a dual function. That is urogenital. So it means that there could also be some traces of sperms along the way, even if nothing went into the bladder. So the fact that there are seen some sperms in the urine deposit doesn't confirm retrograde ejaculation, but the significance of the numbers, significant numbers. So it is important. So that's why I'm bolding this statement. The detection and assessment for significance. Just like you do urine culture. If you do urine culture and there's growth, the fact that there's growth doesn't mean that there's infection. But the growth should be able to be counted to give you a colony count of more than 10 to the power 5. All right. So the fact that you have seen growth in urine culture doesn't confirm that the patient has an UTI. So yes, there is growth. What is the colony count? If the colony count doesn't meet the threshold, then you cannot say that the patient has UTI. Similarly, yes, you did your post-orgasmic urine sample deposit. You have seen sperms. It doesn't confirm your retrograde ejaculation. But the numbers. So what are the numbers? The numbers is that any sperm of more than 10 to the power 5 per high power field in a post-ejaculatory urine sediment is diagnostic. So if you had a post-ejaculation urine sample, you did your chemistry, you did your appearance, or for that matter, physical examination, it was cloudy, you did your urine sugar tests. I'm not saying the glucose. You did the sugar test. It's also positive, and it's likely to be fructose. And then you also did your sediment, and in the sediment you are getting 10 to 15 sperm per half. All these things make the diagnosis even more stronger. All right, makes the diagnosis very strong. All right, so sperms of greater or equal to 5 per half filled in the urine sediment, I'm talking about the post-orgasmic urine sediment, is highly confirmatory. All right, so now let's see. So the patient preparation and sample collection. So let's see how you prepare the patient for. Remember, before you do this, there's always a suspicion. It's like going to do malaria parasite. There should be a suspicion that no, the patient has high temperature, it's happening, blah blah blah. So then go and do your MPs. So there should always be the clinical suspicion. And then you go and do the test. All right. So already the patient is from the history and everything, the clinician is suspecting retrograde ejaculation. All right. So then ask the patient to go and do the PEU. And here our PEU is not a pediatric emergency unit. It is post-ejaculation urinalysis. If a doctor writes this one, that means that you, the clinician or the scientist, should also prepare the patient so that your tests could be taken as how do I put it? The outcome of the result could be taken seriously, because if you don't prepare the patient in the manner that we're going to talk about, you did it anyhow, the results could still be problematic. So the next is to how you prepare the patient and then how you also collect the samples. So before performing the PU, the patient is asked to come prepared in the following ways. One, sexual abstinence or ejaculation for 2 to 5 days. And when we do the semen analysis, I'm sure some of you already have this knowledge already, that if somebody is going to do semen analysis, there should be sexual abstinence. All right. Now, we are saying sexual abstinence or ejaculation because some people will also find means of ejaculating through masturbation. Some people like masturbating. So we say sexual abstinence. What if he doesn't have sex, but he finds a means of masturbating and ejaculating? So sexual abstinence or abstinence from ejaculation. So that's the way to go. That's how to advise the patient. Because you say, okay, don't go in for sex. Okay, I'm not going for sex, but what if he masturbates? It's going to give you the same result as you would have done with the sexual activity. And all of us know, because you are already suspecting that some of the semen volume goes somewhere. All right. But remember that if the sexual activity is also too regular, it's also going to affect the semen flow. So to avoid all these things, that's sexual abstinence, as though the patient is going to do semen analysis. Here, our emphasis is to look at retrograde ejaculation, but you are going to prepare the patient as though he's going to do semen analysis, knowing that we want to be sure that he's producing the right volume of semen. So there should be sexual abstinence or ejaculation for 2 to 5 days before the PU test. Now, on the day, the patient should urinate without emptying the bladder completely. So you are going to do the test. So ask the patient that, oh, okay, so after the abstinence, to give us the urine. Now, pass out urine, but make sure that, and that's where we talk about the mechanism for urination. The other day, somebody was asking me how come that the semen the semen is not mixed with the urine? And I said that that's another medical condition we call climacturia. We talk about that one. But I remember I said that ejaculation, remember, is controlled by autonomic nervous system. Autonomic nervous is involuntary. But urination is voluntary. You can decide to keep your urine. All right. Unless there's what we call incontinence, where the body cannot control itself when you want to pee. All right. Otherwise, urination is fully under the voluntary mechanism. You can decide to pee or not to pee. All right. So when we are saying so because you say that the patient urinate, but make sure that that's empty the bladder. The patient should be able to control the flow of urine. You are urinating. If some has remained, you yourself, you know that some has remained. If everything has come out, you yourself will know. So we are saying that ask the patient to urinate and tell the patient not to completely leave everything, not to completely pee everything out. So the patient, unless the patient has incontinence, the patient should be able to retain some of the urine. Right. I'm seeing some, listen, let me check. I believe we have to do both PUE and semen analysis to get accurate results for the patient with this information. All right. So before the PUE, remember we said that it's like going to do urine culture. I think ideally before a patient will have been asked to go and do urine culture, if you have been asked to do the urinary first, but the urinary will give information whether there is likelihood of infection. But some doctors don't just write the urine culture, and you see that most of the urine cultures are negative because it should have been asked to go and do the RE, and then you see that, oh, this one it needs a culture, it doesn't need a culture. So if you want to do both the semen analysis and then the PU at the same time, it will be a waste of time, a waste of money, everything. So before you ask the patient to go and do the PU, of course, you have done the semen analysis and the suspicion will have been raised. That's what we're talking about. So, Danny, I hope you are getting my. So you don't ask the patient, for example, don't ask the patient to go and do urine and urine culture at the same time. It's a waste. It's a waste. And unfortunately, that's what most doctors do. Yeah, you doing but you see that if you did the urine first, you have seen that, oh, he doesn't need the urine culture. So if you ask the patient to go and do the semen analysis and PU at the same time, I mean, there's no basis. If the semen doesn't show any indication of potential retrograde ejaculation, why do you say that you go and do PU and semen analysis? So what I'm saying is that for the clinician to ask the patient to go and do the PUE, there should be a strong suspicion from a previous semen analysis and also from the patient's own, let's say, history. Because if he tells the doctor that, oh, if I have sex, I don't see anything coming out. Then, okay, first you will ask the patient to go and do semen analysis. Then the lab scientist will also collaborate that one. Oh, I ask the patient to produce the semen either through masturbation or whatever. You try, nothing came out. So you also write a report that it's spermia, nothing comes out. Then that's where the doctor will have a strong basis that then go and do a PUU. Right, so that's where to go. I hope my point is clear now. So now you are preparing the patient. So the next point is to wait for about half an hour. All right. So if you want to, if you want to do the PUE and get the good results, these are the steps. So you wait for about half an hour. The half an hour is still to give. In fact, in some cases, they'll ask the patient to empty the bladder and then go and drink water. Let's say 500 ml water. Go and drink water. And then, but I don't like that option. So ask the patient to, okay. So ask the patient to leave some of the, because after all, the patient doesn't have problem with urination. So if you ask the patient to leave some of the urine in the bladder, and then wait for about half an hour, you will have built a little bit of some urine in there. All right. Then you masturbate and produce semen. When you do the semen analysis, you see why our masturbation becomes our best method for collection of the urine. All right. There are so many reasons why we want to masturbate, and we will do that one on the seminology. So you ask the patient to masturbate. All right. And then produce semen into the specimen container. So it means that here you're going to give the patient 2 containers, one for the semen collection. So you collect the semen, but you are not going to do semen analysis. If you do the semen analysis, who pays for it? The doctor has not asked you to go and do semen analysis. And for that matter, you can't charge the patient for semen analysis. But the the PUU will require that the patient should produce semen, but it doesn't ask you to do semen analysis. You can't charge the patient for that. I hope the point is clear. All right, because the patient has done it already, and there's a suspicion that there's retrograde ejaculation. But for you to do the post-ejaculation urine analysis, the patient will have to produce semen. That doesn't mean that you use the semen for another semen analysis. Yes, you may want to do that, but that is for your own. You can't ask the patient to pay for it. All right. So you produce the semen, and then soon after the ejaculation, of course, by masturbation, urinate into another sterile container and submit the sample to a lab. I hope that this procedure is very simple and any patient can follow it. All right. So the patient probably will also bring the semen and then the urine both to a lab. But I've said that you don't need any, you don't have to work on it. What if the patient, what if there is, remember you talked about the retrograde ejaculation could be complete. If it's complete, then even after masturbation, nothing will come out. So he will bring you an empty container. For the semen one, he will bring you an empty container. He will say that, oh, nothing is coming out. Then you know that, okay, this is a retrograde ejaculation where everything has gone to your bladder and nothing is coming out. So the semen container will be empty, 0. And therefore, you will report that there is aspermia. And then now you collect the urine. The urine will come. Then you see that the urine is clouded. That alone is a strong suspicion. I mean, makes your suspicion even almost confirmed. All right, good. So the urinalysis. So like I said earlier, the post-orgasmic urine samples will be analyzed for chemistry or chemicals, physical, and microscopies. The urine sample will be centrifuged, and I've talked about the physical and chemistry already. Then the microscopy, the urine sample will be centrifuged and cells present in the pellet. Pellet here, we're talking about deposit or sediment, will be assessed for type and quantity. Now here, the recommendation is that you ask the patient to bring, to give you the urine. The urine, everything, I mean, it's not like midstream urine where you ask the patient to pee the initial one to go off, collect the middle one, and then last portion to go. No. Here, everything is going to go. So it's likely that it's going to give you large volume of urine. If it gives you large volume of urine, please spin everything. Of course, the centrifuge tube cannot accumulate more than, let's say, 10 mils. The centrifuge itself is about 50 mils. You don't have to fill more than 10 mils. So if the patient has brought you large volume of urine, if there are even 4 tubes, fill all. And then also you fill all of them, spin all of them, and then now pool all your sediments together and work on them. All right, so that's the way to go. Don't, it's not like you are doing some urine analysis. So the patient brought in a large volume of urine. So you pour the first 10 mils for your medicine and left the rest. No, because you want to analyze the urine for semen or for sperms. All right. So if he brought you a whole container full, please pour them into as many tubes as you can have and spin all of them. When you finish, pull all your pellets and for that matter, your sediments together and do your microscopy. All right. So, like I said, RE, and for that, this RE is not routine urinalysis. So, this RE is retrograde ejaculation. It's unlikely if sperm is absent in post-ejaculate urine deposit. All right. RE is unlikely if sperm is absent in post-ejaculate urine deposit. I want to see if somebody will ask me a very critical question here. Right. So, retrograde ejaculation is unlikely if sperm is absent in the ejaculate urine deposit. I want somebody to ask me a very critical question here, and then I'll know that you are following the discussion. So, still on the lab procedure, of course, the urine sample is adequately mixed and poured into tubes. So here, pouring the tubes, we're talking about if the volume is large, you have to pour them into the various tubes. Of course, centrifuge, as if you are doing the normal urinalysis. And then the tubes are pulled and examined microscopically for presence of sperm. All right. So if sperm cells are seen in the urine sediment, then assessment of the numbers present shall be necessary for confirming or ruling out the diagnosis of retrograde ejaculation. And as you said already, sperm of greater or equal to 5 per half hour fluid in post-orgasmic urine sediment confirm the diagnosis of retrograde ejaculation. I want a question to come. So post-ejaculatory urinalysis. If you did a post-ejaculation urine sediment and you have, let's say, PAR cells 1 to 2 per half hour fluid, epithelial cells 0 to 2, RBCs 0 to 2, sperm 3 to 5 per half hour filled. In this report, retrograde ejaculation is highly unlikely. So you did a test like this, and you report like this to any clinician, you will clap for you, say, yes, my lab man knows his work. You don't just do this one, you did your PU, and then you reported and left it like that. Your comment is very, very critical because sometimes the doctors also don't know what's the cutoff to determine whether there is retrograde ejaculation or not. Because once you have seen that the sperm, the doctor will think that then, okay, there's retrograde ejaculation. The lab person should be able to write a report to say that, yes, there should be a certain threshold. All right, it should be more than 5. So if you are getting sperm 3 to 5, in this particular case, retrograde ejaculation is unlikely. Let me see if this is my question coming. Well, very good. And that's exactly. So Clifford, that's exactly the question. So what would be possible if the patient is suffering from azoospermia? So you see that there are 2 conditions that here. See, azoospermia is that there's no sperms. It has nothing to do with the volume. So if now there is azoospermia, then the semen volume will not be affected. If there's azoospermia, it means that you want the whole volume is coming out. So there will not be any even, what do you call it? Remember you said that before you do PUU, you are already going to do your semen analysis anyway. So if there's azoospermia, you could get your azoospermia right, and semen volume will, let's say, 4.5 or 3. If there's 4.5, it means the standard volume, and therefore you wouldn't suspect any retrograde ejaculation. So the question is very perfect. That's the question that I wanted to come. What is the patient? Because you're saying that the semen, the sperms should meet a certain threshold. What if the patient is azoospermia? If the patient is azoospermia, then we will not be investigating for for retrograde ejaculation. Retrograde ejaculation and azoospermia are two different mechanisms. All right. So if it were azoospermia, yes, the patient will have no sperms, and then also the semen volume will have been met, and therefore there will not be any. It will not give us the situation to think about some of the semen going somewhere. Here you are saying that the semen volume is either 0 or too small, and you are suspecting that something is going somewhere. All right. So that is how we can explain that. Right. I'm getting some large medicine. Please, in retrograde ejaculation, some sperm can be in the urethra that can fall into the urine. So what percentage or how do you quantify them? Also, in the case the patients have no sperm going back to the bladder, but still there's not enough volume which can dry ejaculation, which can be dry ejaculation. How do you classify, or what could be the possible cause? All right. Yeah. So don't let us confuse retrograde ejaculation with, when we do the seminology, you're going to, if there's azoospermia, we're going to have whether there's obstructive azoospermia. You have the knowledge to know whether there's obstruction somewhere. Because remember, we said that semen volume, which is low, retrograde ejaculation is only one aspect. There could also be obstruction somewhere. There could be other causes, except that we said that because retrograde ejaculation is the major cause, and lab scientists should be able to diagnose retrograde ejaculation very, very well, because doctors can only suspect, but the lab that can do the proper diagnosis, and that's our area. So we needed to be able to make sure that. But what if when we are bringing the element of azoospermia and all those things, it will make the retrograde ejaculation principle very difficult to explain. All that we are saying here is that azoospermia is a different mechanism. Retrograde ejaculation is a different mechanism. Now, before a doctor will suspect retrograde ejaculation, you will have done semen analysis anyway. And if the issue is about the numbers of the sperms, I think we wouldn't go and investigate for retrograde ejaculation. We have a situation where even the sperm count can even be normal, but still we are thinking that because it is low volume, we must know where the rest of the semen is going, and we want to rule out that it is not going to go back. Because if it is going to go back into the bladder, then there is a way of support. In fact, there's even medication. There are medication, because when you say some of the semen is going to go into the bladder, and it is partial retrograde. Remember the partial retrograde, you are saying that the closure, there's closure, but the closure is not tight. There are drugs that can support the sympathetic mechanism to be able to contract much more better, and therefore give it a tighter closure. All right, that mechanism. So if the situation is that, oh, the volume, even though the semen, the patient is not azoospermia, the patient has the normal volume, yet, sorry, the patient has normal count, yet the volume is low. Remember, we said that when you have low volume, once the semen gets into the vagina, because of the high acidity, the volume will be consumed by the acidic environment. Remember, but because otherwise you say that, oh, the semen count is normal, the sperm count is normal, the volume doesn't matter. If the semen count is normal, sperm count is normal, the volume is still low, and say it doesn't matter. It matters because, yes, the numbers are high, they meet the normal count, But if the volume is small, at any particular point, the patient will suffer infertility because the volume is not large enough to be able to compensate for the vaginal acidity. So then the doctor will still want to investigate if it is a question of retrograde ejaculation. It can be confirmed by the laboratory. There's a treatment for it, so that the patient can be treated for the partial retrograde ejaculation, and then can improve the fertility state of the individual. I think that's where we need to look at it from. We need to look at it from that angle. Thank you very much. So then we come into the issue that was raised earlier, where the urine is mixing with the semen. This is not an issue about retrograde ejaculation, but rather the semen is coming antegrade, all right, coming former, all right, but there's a leakage of urine mixing up. Okay, so now we are not getting the backflow. Remember, retrograde is backflow, backward movement. Here we are not having the semen going backwards. The semen is coming out, but still there's leakage of urine mixing up with the semen. That's what we call climacteria. You know, remember we said that orgasm is not ejaculation. I hope you remember. Orgasm is a feeling. It's a feeling of that kind of pleasure. It's a feeling. But it is that feeling that will serve as the driving force to push the semen outwards. And so it's like orgasm is usually associated with the ejaculation. I hope that point is clear. Very good. So when you have that kind of orgasm, we say you have reached a climax. I'm sure it's something that all of us know. You have reached a climax. So when you reach a climax and then you're also urinating, that becomes climacteria. But remember that if there are some people who will cry, you are crying and then they are urinating at the same time. You haven't seen some before. Okay, you have not seen some before, but you may have heard some before. Some people will cry and then they will cry and then they are urinating. It happens. In fact, me myself, I've seen some before. No, it doesn't happen to me personally anyway, sorry. But there are some people who will cry, and as they are crying, they are urinating. You see? So there are some people who, in their climax, when they have reached their climax, then they are also urinating. So, but remember, we also that when you reach your climax, that's also the time that you're also ejaculating. So climacteria is when you have reached your climax, which your orgasm, associated with urine. Climacteria, climax. You reach a climax, and then you're also urinating. Climacteria. But remember that the same orgasm is also causing what do you call it? Ejaculation to also occur. So you are going to have a mix of the two. That's different from, don't confuse this one with retrograde ejaculation. I'm talking about somebody who have had orgasm, who have to, and by nature of the orgasm, he has to ejaculate. But the same person too, anytime he's ejaculating, anytime he has that orgasm, then there's also urine coming around. So that's the element of climax and urine, climacteria, urine associated with climax, and that's orgasm. So you call it climax, orgasm associated incontinence. Incontinence is when you are unable to control your urine. I hope the point is clear. So I want you to understand the terminology very, very well. Climacteria is when you have an orgasm or you have reached your climax and you are urinating. All right. And so that's what we call orgasm associated incontinence. There are some people, and I want you to, even though it was like a joke, take it serious. There are some people who will cry, and when they are crying, they will even poo-poo. They will cry and poo-poo. They will cry and urinate. They will cry and do all sorts of things. So there are some people who will reach their orgasm, and then they cannot control themselves but to urinate. I've heard this story where they say there's a gentleman who was a virgin. He hadn't had sex before, and then he had a girlfriend, and then when we were doing it, he was calling the mommy. The mommy was in the other room. The mommy, I'm urinating. The mother said, "Oh, urinate inside." Urinate inside. So, for you know, this is classical climacteria. So the mother was encouraging the guy, so urinate inside. So that's climacteria. You are in a climax and you can't control your urine. So you call it orgasm associated incontinence. That's climacteria. That's a condition. All right. That's a condition. It can happen to people without you can't even explain. But it becomes a problem, especially when there has been what we call radical prostatectomy. Radical prostatectomy, whenever you have total or radical, it means that whole organ. So if you talk about as you move along, you are going to see radical and total use interchangeably. So when you talk about radical prostatectomy or total prostatectomy, it's saying that the whole entire prostate gland has been removed. Once that happens, it is usually associated with climacteria because you know that prostate has a big role in controlling urine flow and what have you. So if the prostate, for whatever reason, the whole prostate had to be removed, it is usually associated with climacteria. All right. I hope that point is also well clear. All right. So other ejaculation problems, of course, you know this already. Hemospermia, the hematospermia, they are the same thing. Either hemospermia or hematospermia, they are the same thing. And of course, the presence of blood in your semen or ejaculate. There's no distinction between visible and non-visible hemospermia. Sometimes people define hemospermia as the presence of physical blood in the semen. And sometimes you may not, it's like blood in urine material. Sometimes you have what we call the gross material or frank material, where the blood is so obvious in the urine, is bloody urine. That's sometimes it is not the case. You see the urine as well as a cloudy urine. You do your microscopy and you see that there are RBCs. All right. Whether the RBCs are physical or through microscopy, they are all hematuria. All right. So if I'm saying so because some would define hematospermia or hemospermia as the presence of physical blood in the urine. But so here we are saying that it may be visible or non-visible. For as long as there's evidence that there's blood, then that could be hemato or hemospermia. It's usually painless, benign, and self-limiting symptom. However, it can present in association with hematuria, dysuria, and scrotal pain. What we are saying here is that sometimes, occasionally, you may see blood in the semen. It's self-limiting, means that it can go off. You don't need to worry too much. So you need to get all this information because as students of andrology now, maybe then somebody will, instead of you going to see his or her clinician, will want to complain to you. So with your knowledge, you cannot give a better explanation and a better counsel, or even to address or to advise the individual with better knowledge. All right. Of course, if somebody also have hematuria, yes, then it could be also a reason for the person to also suffer hematospermia. All right. It can also be due to injury to the male sex organs. And these things are very, very important. And we've said this several times, that sometimes some injuries occur in our lower abdominal area and you don't take it serious. Before you could say, Jack, you are seeing blood in your semen and stuff like that. So all these things are potential causes. Transrectal ultrasound guided prostate biopsy. I'm sure these things, you know that these days, some clinicians will want to take biopsy and then they'll pass it to the rectum, to the prostate area. I'm sure all of us have seen how the prostate can be assessed through the rectum. I think you remember the digital rectal examination, where it said the digital is not like electronic. Digital is your hands, your fingers. Then you are using your fingers to examine the rectum, to pass through the rectum to examine the prostate. So that would be digital rectal examination, DREs. All right. So once you undergo some of these things, it could also produce some hematospermia, but that they can be resolved in the shortest possible time. All right. So we also have transrectal ultrasonography, ultrasound. TRUS. Some of these terminologies, we will just want them to be known to you so that if you see a patient's lab form or something with TRUS, I'm sure you don't get confused. That, so what is this? This is transrectal ultrasound. All right. So if a patient is going to go through transrectal ultrasound, what it means is that the diode is going to pass through the patient's rectum to do a scan, all right, or ultrasound. That's the truth, and so forth and so on. So all those things, once the patient has gone through this, it's likely that you could have blood in the semen. Right. So let's quickly look at some disorders. Some disorders that can also affect the penis. So that's why we wanted to finish with this lecture, because it appears to be one of the longest. So let's finish up so that we could tackle a new topic the next time. So some of the sales disorders of the penis include balanitis, hypospadias, epispadias, phimosis, paraphimosis, micropenis. You leave out micropenis for now. Penile fracture, penile cancers. We have genital was, and in this discussion, I think we will end with the genital was. We're going to look at syphilis, genital herpes, and yes, the syphilis, genital herpes, and then I even left somewhere here, chancroid. They will be discussed on the genital ulcer diseases, ulcers that can affect the penis. And the ulcers that can affect the penis, we're going to tackle it in a different lecture. So today we are going to quickly go through the balanitis, hypospadias, epispadias, phimosis. These are all short definitions. All right. Right. So balanitis is the inflammation of the head or the penis. Remember, we talked about the penis, you have the head, the shaft, and then the root. Okay, you remember these things, right? So if there's an inflammation or infection affecting the glands, that's the head, the tip, then that's called balanitis. Now, prostatitis, not prostatitis, prostatitis, inflammation of the foreskin or the prepuce. Where do you think you can have this condition? Prostatitis is the foreskin. All right, when there's an inflammation of the foreskin. So it means that this condition can only affect the uncircumcised, because during circumcision, the foreskin is removed. So if the foreskin is removed, then it's unlikely that you are going to have prostatitis or the prostatitis. So this is very simple to understand. All right. So we have the balanoprostatitis. Balanoprostatitis, you know, balanitis is the glands, the head, and then the foreskin, the prepuce. The foreskin is the prostatitis. So if both are infected, then it becomes the belenopostitis. It involves the inflammation of both the glands and the foreskin. And remember, this only occurs in uncircumcised males. It only occurs in uncircumcised. Now, often with a foul smell discharge, smegma under the foreskin, you see, the penis, the head of this, especially in the uncircumcised, there's always a discharge. It's like trying to make sure that the place is always wet. And that's called smegma. In fact, I don't know whether you know about Mycobacterium smegmitis. So Mycobacterium smegmitis have to do with smegma to the extent that you can have Mycobacterium. Of course, these ones will not cause tuberculosis. So it means that you can have an infection. If in the uncircumcised patient, you can have an infection that will dwell between the foreskin and the prepuce and the glands. In this case, become the belenopostitis, and you could have Mycobacterium there. What it means that you can get a smear there, you do Z10, you will get what you call AIV positive. If you don't know, you say, hey, the patient has TB from the penis. This is Mycobacterium smegmitis. The smegma serves as like a good source of nutrients for them, and they have a lot of bacteria in there. So for the uncircumcised, you are likely to get a lot of infection. And the next slide will take us to the condition that will phimosis and then paraphimosis. You understand why those things are very, very important. But we are saying that in the uncircumcised, you can usually have an infection that will affect both the glands, which is the foreskin, the glands, which is the head, and then also the foreskin. Both, that will be there. And we're saying that to the extent that you can get Mycobacterium there. The Mycobacterium there is not Mycobacterium tuberculosis. It's Mycobacterium smegmitis because of the smegma. That discharge that is usually found produced by the glands penis to serve as a softening medium, all right, for the prepuce, so that the prepuce can easily be moved up and down. But if a condition can come where the prepuce cannot be moved, that is the phimosis. We'll talk about that later on. But we want us to know that you can get Mycobacterium smegmitis, and the word smegma should tell you that it is around the penis, the glands, and then the foreskin, all right, and that discharge is there. So especially if you are uncircumcised, they attract a lot of bacteria, and then it causes a lot of infection, and then gives some foul smelling scenarios. All right. So balanitis, that infection can be classified as infectious balanitis or non-infectious balanitis, depending on the causative agent. All right. So let's see. So this is the infectious balanitis. So over here, this is the glands. All right. So this is a circumcised individual, and so you don't have the foreskin on the prepuce, and therefore it cannot be belenopostitis. It cannot be. In belenopostitis, you're talking about infection that's affecting the glands and also the foreskin. All right. Now, so infectious balanitis, you're talking about an infectious agent which is causing this infection. So it can be fungal, and the commonest is Candida. We are saying so because, for example, if you have infection affecting the glands or the head or the penis, with this knowledge, you know that the commonest agent is Candida. All right, so I think that alone, so that in case even in case that you didn't even do, you didn't do culture or anything, with your knowledge, you know that, oh, what the agents or the infectious agent that usually affects the head here, they are normally candida. So look for antifungals rather than going in for, let's say, some other antibiotics. So that's why I'm saying that very important to look at some of these things so that you know that, oh, the commonest this is candida. So probably you need to treat it with antifungal rather than going for something else. I hope that you are following the discussion. Good. So the fungal infection is the commonest cause for balanitis. All right. Then the bacteria could also be any of the group B or group A beta hemolytic strep and staph aureus. So this is the next, apart from the candida, the next common infectious agent would be the other any of the strep group B, and I'm sure you know strep group B is strep agaliti, and then strep group A is also strep pyogenes, and then staph aureus. So these are the, so it means that once you also know this one, then you are also going to go in for antibiotics that is targeted to the gram positives. All right, so that's why all this information is very, very important, that you should know some of these things. So that, oh, this one, let's treat it with, or let's manage it with antifungals. Or if you also want to also give you some other antibiotics, then you look out for any of the gram positives antibiotics. All right, rather than going for broad spectrum antibiotics and so forth and so on. So you are doing targeted management, right? So the next, it can also be a viral infection. All right, and it's herpes simplex. You are also going to do hepatic genital herpes on another discussion, but the infection can also be, like we said, the highest is fungal, which is candida. Next highest, the second most common would be the gram positives, and then can also be viral. It's viral, of course, you know that it's self-limiting. It can go on its own. All right. It can also be protozoa, T. vaginalis. So it is not true that T. vaginalis is only seen in females. I'm not sure this is going to be T. Penile, peninalis. No, this will be still T. vaginalis. It can cause, especially these things occur very much in the uncircumcised people. Now, in the uncircumcised people, cleanliness becomes a problem. I mean, they don't manage the foreskin so well. And I said the smegma serve as a good nutrient for a lot of the bacteria, even including mycobacterium, and then cause a lot of these infections. So all of them can come. And of course, Sarcoptes scabies. Where there's a bullet in the head. And I'm saying that most, sorry, most of this, once you have this knowledge, you know how to manage the patients. Please don't go and make yourself a doctor to manage, but at least you have this information and then you know, oh, this is possibly the cause. And once you also help your clinician with this information, that's where they also have confidence in you and then can see you as a good partner in managing patients. All right. So especially in the uncircumcised individuals, chemical irritants, detergent, and spermicides. So, you know, if you put on the condoms, the latex, the latex in them are spermicidal, and sometimes they irritate. And once they irritate, they can cause some sort of bruises at the at the head of the penis, and that is not an infectious one. So as a result of the irritation and then the allergy. Of course, we also have drug allergies, morbid obesity. If you become so huge, you can't even move, and then it means that the penis will not be mobile. So it will rest now before you could say Jack, it has become infected. So that is so local traumas. So these are things that can also happen to the head or the penis to cause an infection, which you call the balanitis. So it could be infectious, it could be non-infectious. Where it is non-infectious, you look out for what could have happened. If it's a chemical irritant, of course, you advise the patient to avoid that kind of chemical, and then you can go without going for any antibiotics. Right. Right. So this is another interesting area, penile disorders. Hypospadias. Hypo means below. All right. So this is a birth defect in which the opening of the urethra, all of us know the opening of the urethra will open at the tip of the penis. All right. The urethra will open at the tip of the meatus. It will always happen at the tip of the penis. Sometimes it doesn't happen the way we expect it. Now, so remember that the penis, the urethra can open below the shaft, the underside of the shaft. All right, we'll take you to the next slide. And then once that is happening, we call it hypospadias. So you expect the urethra to open at the tip of the penis, of the head. If it doesn't, then rather open somewhere below or on the side of the shaft, and I'm sure you know the penile shaft now, then that's called hypos. So below, any side below the shaft, then that's a hypospadias. So it can be very severe. It can be mild, depending on where we have the subcorona. Here, the urethral opening is located somewhere near the head of the penis. I'll get you the pictures for it, and you see the mid shaft. So this is the urethral opening located along the shaft of the penis. Penscrotal, that's close to the scrotal. So the opening located where the penis and scrotum meet. All right, and then perineum occurs where the opening is behind the scrotal sac. So these are the pictures. Penile spread. So you see that normally, excuse me. So normally this is the tip of the tip of the penis or the glans. So you expect that normal urethra should open at the tip here. Now, anywhere along this line, the urethra can open. So instead of opening here, it can open. So this is the gland, so it becomes glandular. Okay, and then the subchora, that's the head of the penis. The ring down is subchora. So this one. So all we are saying is that, so instead of opening here, it can open along any of this line. And so the further it goes, the more severe the situation is. The extent that some can open somewhere behind the scrotum. All right. So, and all these are conditions called the hemospadias. So as students of andrology, you should have some of this information so that, yes, you are not a clinician, you are not a doctor, but at least you have the knowledge. You'll be there and then somebody can tell you, oh, I have my child and I see that baby, oh, this is a medical condition, it can be corrected surgically. And especially those ones that are around the glandular, I think they can, for as long as the it does not compromise the health of the patient, I think they may not even need treatment. But those that come all this way, they have to be reconstructed. The uterus has to be reconstructed to open at the tip. All right. Then the opposite of hypospadias are epispadias. Here, and remember, all these are birth defects. The hypospadias and then epispadias. Epispadias are the opposite. That instead of now opening below, this one is opening above or side of the urethra. So that is the epispadias. So apo below, epispadia above or sideways. That's very easy to understand. Right. These are things that we need to quickly look at. The phimosis is a condition in which the prepuce, and for that matter, the foreskin of an uncircumcised penis cannot be retracted over the glans penis. Here we said that the especially in balanitis and then the balanopostitis, we said that the foreskin in the uncircumcised individuals will have to be pulled back so that they can do some cleaning, because we said that the good hygiene can prevent some of the causes of balanitis. So you expect that the prepuce in the uncircumcised patient should be able to be pulled back, all right, so that the patient can clean the glans area and remove the smegma as much as possible. Remember, we said that smegma can be foul smelling and so forth and so on. So the individual can do the cleaning, but there are some people that send that the prepuce, if you attempt to put them back, retraction, they can't retract. So once they cannot retract, it means that you can't even clean the glans area, and they are those people that are prone to balanitis. So if the foreskin cannot be retracted back and then released back, then it means that it's a problem. That's what we call phimosis. So, and this is also congenital to some extent. So if the patient is having phimosis, then this patient has a high risk of having balanitis and, for that matter, balanopostitis. All right. And then we have the paraphimosis. Paraphimosis is like the priapism that we talk about. It's a medical emergency. Here, remember we said with the phimosis, it cannot be retracted. The foreskin cannot be retracted. Here, you're talking about when you retract, you should be able to be repositioned. It should be able to return, go back. So if you retract and it cannot go, it cannot return, it cannot be released, then that is because once you retract, all right, then it's sort of like strangulation of a sort. It's like you have used the prepuce to tie the neck of the glans, and so blood flow and everything will be compromised. All right, so that's paraphimosis. Phimosis is that you cannot retract it at all. Now, paraphimosis, you retracted it, but once you retract, the thing should be able to go back. If it cannot go back, then it serves like strangulation. All right, and that is a medical emergency. So I'm sure you can appreciate the difference between phimosis and paraphimosis. All right, thank you very much. We'll finish very soon. Penile fracture occurs when there is rupture of the fibrous tubular tissue in the penis. It is usually caused by erect penis forcefully striking the female pelvis. I'm sure this one you can appreciate it. All right. So penile fracture, you will have an erection. Instead of you take your time and penetrate, you won't do that. You want to force the thing before you could say Jack, you hurt yourself. And remember, these are some of the things that will cause the scarring, because you now injure your penis. The tissue in the penis become injured, and then it forms scars. that now becomes a plaque that will now cause the distance to curve in the condition called the paranoise. All right, so these things, I'm sure you easily appreciate them. So if you have an erection, please take your time to penetrate. Don't force, otherwise you cause a fracture. All right. You can also have, you are also talking about conditions that can affect the penis. You can have penile cancers. Penile cancers, cancer of the penis almost always begins in the skin. And remember, the skin of the penis is just like the skin of the body. It is squamous, stratified squamous, and they can be cancerous. They can be cancerous. And so when the squamous cell become cancerous, I'm sure all of us know squamous cell carcinomas. So squamous cell carcinomas are the commonest cancers that can affect the penis. And of course, sometimes they begin like a blister, like a blister, like a small pimple of a sort. All right, especially on the foreskin. And remember, foreskin is for the uncircumcised. So people who are uncircumcised are prone to a lot of conditions. And that's why I'm sure in our Ghana culture, almost everybody is circumcised. But of course, we still have some people who think that they don't need to be circumcised. Yes, nobody can force you, but you need to be able to take good care of it. You have to have good penile care. You have to take good care of the health of the penis. Otherwise, you could have a lot of challenges. All right. So there are 5 basic types of penile cancers. The commonest, like the squamous cell carcinomas. You have the melanomas. Of course, as the more you go deeper. All right. So the surface one will be the squamous cell. You can go deeper and deeper and deeper and deeper. So those are the other types: melanoma, basal cell carcinomas, adenocarcinomas, and then sarcomas. All right. So just for your knowledge, just to have an idea that the penis can also have cancers. And the commonest one is the squamous cell carcinomas. And they account for about 95% of all penile cancers. All right. So you can have carcinoma in situ. I intentionally brought this one there so that when I say carcinoma in situ, it doesn't mean anything. Just say that it's the earliest stage of the squamous cell carcinoma. All right. Sometimes you got impression that when you say carcinoma in situ, you're talking about a deep-seated carcinoma. No, please. So it is just the early stage of the squamous cell carcinoma. In this case, at this point, if there's some histology which say that carcinoma in situ, it means that this is the stage that can easily be treated or managed, because all of us know that when we have cancers which are diagnosed early enough, I think you have very good chances of recovery. All right. So we also have the age, promiscuous sexual behavior. Of course, that will be multiple sexual partners. HPV is human papillomavirus. If you have positive for human papillomavirus, tobacco use, poor hygiene, these are all risk factors for developing penile cancers. So that's why we said that people who are uncircumcised, when we talk about poor hygiene, we're talking about the health of the penis. All right. And those who are uncircumcised, they have higher risk, for example, of developing bilionitis, biliopostititis. They are at risk of developing some blisters, which can now also tend to become squamous cell carcinomas and so forth and so on. All right. So there are some interesting terminologies here. And like I said, as students of andrology, ours is to know about some of these things, not necessarily going to treat patients, but at least even if a treatment guide has been produced or has been given out, as students of andrology, you should be able to understand that, oh, once this is the situation, this is likely to be the case is going to be managed, and this is how it is going to be done, and so forth and so on. So in patients with invasive penile cancers, remember we said that the squamous cell carcinomas, those are on the surface. But if let's say you have the melanomas which are now going deeper, all right, or the sarcomas which are born very deep, then it means that they are born deep to the extent that they have affected the corpora. I'm sure you know about the corpora cavernosus and then the spongiosums. All right. So, and those are the tissues that are lining the urethra. So if the cancers are penetrated to that extent, then it means that there should be some sort of removal of a sort. All right. So depending on where the extent of the invasion, then there could be surgical intervention. And so we have the glanectomy. And remember, it can be partial or total. Remember, when you say partial, it means a part of it. When you say total, total is the same thing as radical. Total glanectomy means the whole, it means that the entire glans head will be removed. All right. And normally when these things are removed, there could be some artificial kind of manipulation that will try to restore your dignity. But I just want us to know as students of andrology that when you say glanectomy, you are talking about, it could be partial or total. If it's total, it means that the entire glans, the total head, the entire head of the penis is removed. You also have partial or total or radical. Remember, total or radical is the same thing. When you say total or radical, it means the entire organ. And now penectomy, of course, penis, removal of the penis. So the entire penis will be removed. I think they say that it's better to go to heaven with one arm than to go with than to die with both hands. So if there's a cancer of the penis and you have to lose your penis and get and retain your life, I think even though unfortunate as it may be, I think it's going to be a psychological trauma a lot, but I'm sure that if they want to live without penis, than to have penis and die. All right, so that is penectomy. It can be partial, it can be total. When you say total or radical, it means the entire organ. All right, partial means part of the organ will be removed. Here, we're talking about glanectomy and penectomy. All right. This will be our last lesson for the day. And we're talking about genital warts. Warts. We call it genital warts or venereal warts or condyloma acuminata. All right, they are the same thing, depending on who is describing them. All right. So they are caused by human papillomavirus, the HPVs. The HPVs. They cause genital warts. And I'm sure you have a good appreciation or a good appreciation of what warts look like, warts. All right. So you say genital, when you talk genital, because we are men and the whole thing is andrology, we are looking at the men factor. But the HPV is like more serious in women. All right. To the extent that the HPV become precancerous. Once you have HPV, the genital warts, the likelihood of also getting a cancer is very, very high. So we say they are precancerous. It means that when you have it, it's like they are likely to get a cancer of a sort. So they are more problematic, become more of a health problem in women than in men. All right, as far as I know. So genital warts are also called venereal. Venereal will tell you that they are what? Sexually transmitted. So warts will not just, you will not get warts and say that, oh, because authority be so then as some people do. Because maybe then because authority so no who say this condition. It is a sexually transmitted disease. Was and for that matter, human papilloma viruses are sexually transmitted. All right, so that's why some people call it venereal was. And the genital was because they are usually around the genital area. All right. So, and then condyloma acuminata, that's the medical name. So that's why you can have it, either of them. But they are caused by human papilloma virus. They appear as small soft bumps, flesh colored because like they are like part of the flesh. All right. So what's that? That said they are flesh colored. Cauliflower shaped, smooth to touch, and are usually found in clusters. All right. So that's how wasps look like. I'm sure I'll share a picture of it, and then I'm sure you can easily make out. You can make them out whenever you see one. Right. Common locations include the vulva, the vagina, anus, cervix, penis. Because you're dealing with penile disease, that's why you're highlighting the penis. It can also be the scrotum, the tire, and then the groin. All right. So on all these parts are considered to be around the genital area. So that's why they are called genital warts. All right. Good. Now, so you see venereal or genital warts. This one is in the anal region of the perineum. So you see here. So you see these things, they normally occur in clusters. So this one in the anal area. Okay. All right. So these are all genital warts. Right. They are sexually transmitted. So this one, I'm sure these are the gays, the gay people. They are likely to have some of these warts in the anal area. Okay. Now, this is an important information. Remember, we said that genital warts caused by human papillomavirus are sexually transmitted. And for all we know, sexually transmitted disease, if you want to prevent them, you have to do so using what we call barrier methods. Barrier methods is the use of condoms. Okay, so either use a barrier for you to prevent yourself from getting an STI, use a barrier method, and the major well-known barrier method would be the condom. Or by abstinence, that you abstain, you won't go for any sexual activity at all. So it means that you are preventing it. So to prevent an STI, you either use a barrier method or by abstinence. However, you said that genital warts are also sexually transmitted. However, HPV cannot be prevented using vaccines. So this is a very important information as andrology students you have to know. That even though most of the STIs cannot be prevented by vaccines, we have the HPV, the human papillomavirus, which can be prevented by vaccines. All right. And 2 vaccines are currently licensed to prevent HPV. And it is important as students of andrology to have this knowledge. So that, like we said, the genital warts, and for that matter, human papillomavirus in females, they are precancerous. And all of us know how devastating cervical cancers are. And so if you have HPV, the tendency is that you could have cervical cancer. And so if now you can be vaccinated, it means that is a very good news. And we have to be able to, for as much as possible and for as much as they are available, encourage young ladies to get vaccination against HPV. All right, good. And like I said, we have 2 vaccines. There's Cervarix and then a Gardasil. One is UK and one is US. All right. The last slide, which is also very important information, is how do you diagnose genital warts? I'm sure we know how to diagnose a lot of disease conditions. The fact is that there's no routine test for human papilloma virus infection in men. Remember, we said that the warts, and for that matter, the human papilloma virus infection challenging in females. In females, they cause a lot of cervical issues. Now, for women, if you do the pap smear, I'm sure all of us know pap smear. If you do the pap smear, if you have a good pathologist, you should be able to diagnose HPV infection if that individual has HPV infection. So in women, you can do a pap smear, and then HPV infection can easily be diagnosed, right? However, in men, the only way you can diagnose HPV is when the warts have actually emerged. So unfortunate. So there's no way you can screen for. So in women, you can screen for HPV. Is that not it? Because you can do your pap smear and screen for the HPV. In men, you can't do that. There's no known test for HPV infection in men. You can only wait to see the warts. When the warts have emerged, then that's the diagnosis. If you're going to do blood tests for this, and there's no known test for HPV in blood or in urine or in whatever. I'm saying that for women, cervical, and for that matter, pap smear is good. To the extent that now there are even DNA analysis. Having taken your pap smear, there can be a DNA analysis to look out for the HPV. There can be PCR analysis for that. All those things are possible for cervical smears, and for that matter, pap smears. For men, you can only wait when the warts have actually emerged. Now, sometimes you may see some blisters there, and you want to rule out whether they are warts or not. That can easily be done, but that's not a lab test per se. So if genital warts are not visible, particularly difficult to see flat lesions. Some of them look so flat. I mean, the one that I show you in the anal region, I'm sure anybody, even inexperienced person, will look at it and know these are warts. Right. There are some that are not too visible. They don't look too. They become difficult to see. They look flat and they don't look the typical warts. If you want to rule out whether it's warts or not, there's what we call the vinegar white test. And I'm sure you know vinegar. Vinegar is acetic acid. I'm sure a lot of women use vinegar in their cookeries and what have you. And as scientists, I'm sure you should know that vinegar is nothing but acetic acid. It's not the glacial acetic acid. The diluted acetic acid. And once it is diluted to 5%, that is vinegar. All right, so that's also an additional information. So if genital warts are not visible or particularly difficult to see lesions, then use the acetic acid and for that matter, vinegar white. What does it mean? What it means is that if you use the vinegar or 5% acetic acid to apply to the warts, the wart area, it turns white, becomes white. It becomes white. Very simple. But remember, we said that warts are flesh looking, like they are like part of the it or certainly times become white. So that's why we call it the vinegar white. And for that matter, acetic acid white test. This one is not a lab test. This one, anybody can do it, and you can train anybody to do it. You yourself can also do it. This is the only way you can confirm that this lesion on your genital area is wax or not. You can't go and do, I'm talking about the men, please. I'm not talking about, I'm saying women, you have the benefit of the service. Cervical smear and then a pap smear can easily be used to check for HPV. But for men, you have to check and find out whether a certain lesion there is wax. If it's wax and it is very obvious, yes, that's it. The patient can be asked to go and see a clinician to manage it for the individual. If you are not too sure whether it's wax or not, this simple vinegar white test is, you don't need to go and see a clinician to do it. Anybody, you can train anybody also to do it. Vinegar is nothing but 5% acetic acid. All right, you apply it to the lesion, and of course, it will turn white. And that is a confirmation of the lesion as genital was. So that we can have time for the others. And there are classically three of them. Hepatic ulcers, that's caused by herpes, and the viral coughs. We also have the chancroid, which is caused by a bacteria called Haemophilus ducrei, and then you have an ulcer caused by the almighty syphilis. So when you have seen an ulcer on the penis, it can either be syphilis, it can be hepatic, it can be a chancroid. So we will look at these three together under genital ulcer diseases. Then that will bring us to the end of the penis. Then you're going to take the scrotum, and then look at all the abnormalities that can affect the scrotum, and then the testis. We're going to look at the abnormalities that can affect the other organs of the reproductive system. Then when you are finished, you go in for the almighty seminology. Thank you very much once again for your time. If there's any question, please let them come. Otherwise, we meet on Thursday.